Good afternoon, everybody. So I'm going to try to touch on some of these points around precision oncology, particularly with regards to patients with metastatic bone disease who are relatively underserved by the current technologies that we have. So, for example, the most common cancers, breast and prostate cancer, the bone represents the most common site of metastatic disease. Yet the evaluations of metastatic disease are still stuck in technologies from the 1970s. So this is typically what you would get in 2018 at every hospital, everywhere in the world, a bone scan that depicts what looks like osteoblastic metastases, although the report says I'm not really clear about this. But if you looked at the distribution of this disease, then clinical trials data suggests that this is low volume disease and that this patient would not benefit from the addition of chemotherapy over the use of ADT alone. And if this patient was in the clinic, you'd say you've got about 5 years to live. Now, if you were to do an MRI scan, what you would see is something very different. So here you see that this is the same patient, and here are the dates. You can see that this patient has what we call polymetastatic disease. Not just a few metastases, but lots and lots of metastatic disease. So what that means from the patient perspective is that he no longer has low volume disease, he in fact has high volume disease, and if you use the treatment that you were planning to do, he would live on average 34 months, not 5 years. If you gave him chemotherapy, he would live on average another 18 months. So you can see how in this particular patient, when remember, precision medicine is the right treatment for the right patient at the right time, you would have got this wrong. You would have got this wrong completely, and this patient would have lost 1.5 years of his life because of the bone scan which was made, which was used to make that decision. And that's important for him, and it's important for the community. We also find the same problem with CT scans. So here's somebody receiving a really expensive therapy. So here's the MRI, here's the CT scan. And on subsequent occasions, using conventional response criteria, we call this completely stable on 3 separate occasions. We do the MRI and we find that this patient is progressing, right? So this is a problem. This is a problem because of this drug. This drug costs $150,000 a year. So how can it be acceptable to spend $150,000 a year and not know what the hell is going on? From a societal perspective, this is an issue. This is a cost issue. And we need better tools to be able to tackle this issue of not being able to detect disease or monitor the response, which is why we're interested in whole body MRI as a method for looking at detecting disease as well as for monitoring response. We know that when we use whole body MRI scanning for this purpose, it reflects biologically important properties, such as the cellularity, and this has been shown by numerous studies looking at the bone biopsies and saying how many cells are in that. We also know that the changes that we see on ADC maps is biologically important because it tells us about cell kill or cell viability. So in this particular example, you see the histogram shift. The histogram shift represents cell kill. But you can also back map every voxel onto the body. And you can see areas of resistance that are developing. So you can see, for example, in this particular patient, in this particular area, this tumor has not responded. And if you were to drill that with a needle, you can find genetic abnormalities in those areas. So for example, here's a patient with a high signal intensity and a low ADC value. We drilled the bone marrow over here, we found a BRCA mutation. When you have a BRCA mutation, we know we can use something called olaparib. Olaparib is a targeted therapy towards that genetic defect. When we treat the patient, you can see the ADC goes up, and I've already told you a rise in ADC equates to a cell kill phenomenon. But look what happens subsequently. Here, we see an area of resistance. High signal intensity on the high B value, a low ADC. When we drill that area, what you notice is the BRCA mutation has reversed, which is interesting. So the tumor is clearly adapting to the types of treatment that we are giving, and this represents Darwinian evolution. And this Darwinian evolution, we can see, is responsible for spatial heterogeneous responses. So here's a patient that I've looked at 7 times. Here the patient's getting androgen deprivation treatment for castrate-naive cancer. Here the patient is receiving another type of treatment, abiraterone, for castrate-resistant prostate cancer. It's incredibly interesting to see that the patient progresses, and when I switch therapies, you can see that the disease in this area here has responded, but this tumor has not responded, and a new metastatic sites have appeared within bone, so a completely different organ. This is Darwinian evolution occurring right in front of your eyes. This is what we want to be able to depict so we can biopsy it and find out what mutations are going on so we can have the right treatment for the right patient at the right time for the right duration. So how do we achieve this? We achieve this by doing whole body MRI scanning, which is fast, consistent, artifact-free, every single time. And we've been working with Siemens for some time to develop what's now called the whole body dot engine. So essentially, it enables you to do a standardized whole body MRI examination that is artifact-free, so that we can get rid of artifacts such as this, which is the broken spine artifact, which used to be very common, but now is increasingly rare. This quality improvement is essential if we are going to take this technology forward. If we do this, work with our industrial partners, we can get examinations like this in very reasonable, patient-acceptable times so that we can examine the whole body in this way. Not only that, but we want to be able to quantify the amount of patient benefit with a therapy. So here, for example, you can see a patient where red areas represent areas of therapy resistance, green areas represent areas that are highly likely to be responding, and yellow areas represent areas that are likely to be responding, a traffic light system. This traffic light system is incredibly impactful in the clinic, and this has been done on Single Frontier and is now being translated into the Single VF platform. So this is an example of what you can do on a Frontier platform that then gets translated into a product which many of you can then access through your own departments. Not only that, but we're interested in knowing, quantifying how much viable tumor there is. So in this particular case, we've got 97% alive tumor. In this particular patient, we have 11% alive tumor. So this patient clearly needs more treatment. So the vision is that the whole body MRI will replace the current ineffective and wasteful methods of oncological imaging, particularly in the bone marrow. And we are already seeing it approved for multiple myeloma, Li-Fraumeni syndrome, and many of us are already using it for bone metastases. There are international standards that show you how to do this. It really has the potential to change the way an oncologist thinks, and if an oncologist thinks differently, he can act differently. And really, it will help us to deliver the promise of precision oncology for this patient, which of course is the right treatment for the right patient at the right time and for the right duration. Using next-generation imaging technologies, together with next-generation sequencing, etc., we can pick the right treatment, we can monitor treatments over time, we can switch treatments in a timely fashion and try to keep patients as well as possible for as long as possible. And this is what I attempted to do in this particular patient. So over 3 years, we used whole body MRI scanning, we monitored the amount of active disease, and we switched therapies. As soon as the whole body MRI suggested that the patient was progressing, before the patient clinically progressed. Now, this patient died, right? There was no way I could get over the Darwinian evolution of cancers. But that technology enables us to have a go at this to try to keep, as I said, the patient for as long as possible, for as long as possible. So tool developments like these are essential because they can allow us to validate and then qualify whole body MRI scanning in the precision oncology era for patients with bone disease. Thank you very much.